The problem is not the doctors, the hospitals, the insurance companies, the et ceteras. The problem is the system of care we have accidentally evolved into, which is fee-for-service based.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. Today, we're connecting with the West Coast out of Los Angeles with Dr. Brad Spellberg. Dr. Spellberg is the Chief Medical Officer at the LA County and the University of Southern California Medical Center, and also the Associate Dean for Clinical Affairs at the Keck School of Medicine at USC. He's the author of a recently published book, Broken, Bankrupt, and Dying. Welcome to the podcast, Brad.
Thank you, Bob. I appreciate it.
So I think this is our 70th edition of the podcast, and on occasion, we've been able to feature a number of books. Experienced people like yourself. They were all medical doctors like you. We had Marty McCary from Johns Hopkins. He had a book out, The Price We Pay. Mm-hmm. And we also had Dr. Vivian Lee from Verily. That's one of the Google companies. She had a new book out you're probably familiar with called The Long Fix. And your book comes along right in theme with a lot of the things that people are talking about. And I think the title of your book, Broken, Bankrupt, and Dying, it's not very motivating, especially from USC. You expect to say "Go Trojans" or something here. So
I work for the County of Los Angeles.
Okay.
The LAC+USC Medical Center is a public hospital. It's a government hospital.
Yes.
Run by the County of Los Angeles. I am not employed by USC. USC provides the physician staff via contract between the county and USC.
Good clarification. Thank you. But tell me about the name. Was that hard to determine for this book?
The publisher really helped me brainstorm. Here's the point. This book is about how the healthcare system is crushing Americans and their families, and frankly, American businesses. That our healthcare system was never actually designed to deliver healthcare. It is an accidental outgrowth of history. And as a result, it performs terribly and costs astronomically more than any other healthcare system in the world.
Yeah, I like that term that you used in the book, accident of history. And I guess that's so true. If you look back at the many mishaps where things could have been done differently, circumstantially, things changed quite a bit. And even today with COVID-19, we're in the middle of another mishap, if you will, not necessarily planned, but things do happen along the way. Wars happen, different political activities happen, etc. But I think the point that you're making with this is right in line. There's a number of topics I'd really like to kind of review with you to get your perspective on it. But what I really liked about your book, at the end, you really get down to addressing what do we want? What do we really want from our healthcare? And how do we go about getting it? And, I think we're like 90 plus days away from a presidential election. Uncommon. You don't see any topics or debates or conversation taking place. I know that healthcare has got to be one of the number one topics that people are concerned with today. And as we uncover some of these facts and figures, I think it's revealing. I think it makes a really strong point. And ultimately, we're going to kind of wrap up here at the end with some of these solution perspectives that you have, because you've got a lot of experience and you've seen a lot of things. And sometimes when you hear the titles of these books and the problems that are wrong, you want to think that some of these doctors don't care and they're manipulative and they're evil people. And we know that's not true.
I think it's really important for people to understand this fundamental point. The U.S. healthcare system was never designed. It organically sprang into being as a side effect of combating inflation after World War II. So when you ask, what is it we want? That is what we have to start with. Other countries in the world have sat down and rationally designed a healthcare system. The first thing you need to do when you rationally design a healthcare system is ask, what is it the people in that country want, so that we can develop and design something that delivers high quality care at an affordable price within those specifications. And our system did not ever go through that process. And as a result of that, nobody ever sat down and asked, what does the population as a whole want? And what we find when we talk to people is different people want different things. There's people that feel very strongly about single payer. There's people feel very strongly about private multi-payer. And most of the solutions you hear discussed pretend that those two solutions are incompatible, that they cannot be intertwined, that you must choose one or the other, and that therefore one side in this partisan argument and bickering is going to win and the other is going to lose. And that is one of the reasons why no one has been successful yet at fundamentally reforming our healthcare system.
You make reference to a euphemism about New Year's resolution. Why don't you expound on that just a little bit for our audience? How healthcare is like a New Year's resolution?
Well, so a couple of years ago, I was part of the American Association Advancement for Science Leshner Fellowship in Public Engagement. One of the activities we did was go to Capitol Hill and meet with House and Senate staffers and talk to them about the issues that we were focused on. And I was focusing on healthcare. And the thing that I heard over and over was like a mantra, over and over and over. Why would we change the healthcare system? It's working for Americans. And I'm like, it's working for Americans? We live shorter lives than all peer nations. We're ranked 26 out of 35 OECD countries. That includes poor countries. People in Peru live longer lives than us. On lifespan, according to a Gates-funded study, we tied with Montenegro and Estonia and lost to Croatia and Kuwait on lifespan. And we pay enormously more than any of those countries for the privilege of dying younger. In what way is our healthcare system working for Americans? And what had occurred to me was that it's working for Americans in the same way that New Year's resolutions work for Americans, which is to say, we do them. Every year we do them. We do them over and over and over. They don't actually deliver what they're supposed to, but out of force of habit and inertia, we just continue doing them. And then we think, it's working for us.
Going back to that fundamental question, why haven't we stopped and really asked the population, what do we want? Recently, we did a podcast on the topic of Agile. It's a quality technique of really looking at fundamental things, finding out the rudimentary points of interest, the true things that we really, really need. You know, I think one of the biggest lies, if you do have insurance, and I'm so fortunate, I have insurance, and so I believe that I'm okay because I've got insurance. But we don't even go deeper into that topic and say to ourselves, well, what is my deductible and copay, and what meds are covered, and is physical therapy covered? Is rehab or emergency room covered? Is inpatient care covered? And when it's all said and done, we haven't done a very thorough job of analyzing what we really do have and what we really do need and what we really do want to have. So I think that's the big point you're making. Talk for a moment about the evil thing. I call it evil. In our classes, we teach about value-based pricing. We're trying to educate and leverage people away from fee-for-service. Give us your perspective on the evilness of this fee-for-service philosophy and how we might be able to change it going forward.
Yeah, so I agree with what you're saying. I would suggest we avoid the use of the term evil.
Okay.
Because the fee-for-service is an intentional thing. And the question is it the intentional thing we want for healthcare? So we'll go back to the point that you made a few minutes ago, that we're not in this mess because doctors are greedy or evil, or hospitals are greedy or evil, or frankly, even because health insurance companies are greedy or evil. In the current healthcare system we have, each of those individuals and groups is doing what they're supposed to do for this system. And that is the problem. As Paul Batalden is quoted as having said, every system is perfectly designed to produce the results it gets. The problem is not the doctors, the hospitals, the insurance companies, the et ceteras. The problem is the system of care we have accidentally evolved into, which is fee-for-service based. I get paid more to do more things to you. I'm incentivized as a healthcare system to let you get sick, because if you get sick, I have to do a bunch of invasive things I'm going to get paid more for. Even the health insurance industry is not incentivized away from that model. It just ratchets up your premiums and leaves you larger and larger deductibles. We're looking at $20,000 a year premiums now, family coverage on average in the United States, with a $1,600 per year average deductible. It's outrageous. So we just it's fine if costs go up, we just pass them along to the consumer. A more rational way of thinking through healthcare delivery, where you align the interest of the patient, the provider, and the payer, is to move towards global budgeting and away from fee-for-service. I'm going to give the healthcare system a fixed payment up front. Your mission, keep people healthy. Keep them out of the hospital. Don't let them get sick. You're not going to get paid more to do painful, invasive procedures. You're going to lose money the more often you have to do that. And now the alignment is the patient is focused on being healthy. The healthcare system is going to get paid to keep people healthy. And the payer gets to keep their costs down because they're not ratcheting through a tidal wave of expensive, invasive procedures.
So this concept of global budgeting, it sounds complicated, but I've started a few small businesses and worked in some larger companies as well. And, if you want to make a profit, and it might be the purpose of your business, but if you want to make a profit, if you can do a reasonably good job of predicting what your income is going to be, and if you can carve off and say, I'd like to make a 10% profit, and then what's left is your budget for expenses. And you just don't go over those expenses. And guess what? You'll make a profit that way. It sounds so simple, but in concept, that's what global budgeting is. You allocate the appropriate amount of expenses. And how does that get you away from the fee-for-service model?
Yeah, great point. Two anecdotes or two stories to illustrate these principles that you're talking about. In the book, I quote an article from Vox.com where they interviewed a CEO of a hospital in Maryland. Maryland is a demonstration project for Medicare. They've switched their acute care hospitals to global budgeting. The CEO of this hospital that was interviewed said before global budgeting, he used to get very anxious when there were open hospital beds in his hospital because it meant he was burning the cost to staff the beds and wasn't bringing in revenue, and that was putting his operational budget at risk. He wanted people to get sick, to need to get into the beds in his hospital. With global budgeting, his entire orientation is 180'd around. Now he's thinking, boy, all these patients in the hospital, I'm not getting any extra revenue for them being in the hospital because my upfront budget is fixed, and I'm letting them get sick, and it's costing the hospital operating budget more. My alignment now is to keep people healthy and out of the hospital. That's one anecdote. The second thing to remember is that in a scenario of fee-for-service where a private health payer, insurance company, loses money when sick people are enrolled, they only make money if healthy people are paying premiums, is it stifles innovation. How so? Well, let's say you become sick and you're paying your premiums and now you need very expensive chemotherapy for your cancer. I have a lot of incentives in throwing up barriers to get in your way so you can't get authorization for that very expensive treatment to be administered. Innovation is the opposite of what I want there. I want to slow things down. I want to throw in bureaucracy. The proof of this is a fascinating study I quote in the book that looked at private nonprofit, private for-profit, and public hospitals and compared the administrative costs in those three hospitals. Which of the three types of hospitals in the United States has the highest administrative cost burden? Private for-profit, private nonprofit, public. You would think it's public. They're not under profit pressure. Why should they keep their costs down? It's exactly the opposite. Private for-profit hospitals in the United States have the highest administrative cost burden. Why? because every dollar they invest in that administration throws up barriers to keep expensive costs out of the hospital, right? If they can find ways to keep paying patients in for surgeries and keep expensive people with psychosocial needs out, every dollar they invest into administration goes to their bottom line. Public hospitals, we take everybody. We don't need all that extra layer of bureaucracy. We're taking who comes to us. If you want to stimulate innovation, give a fixed budget up front and tell people you're highly now incentivized to care for everybody by keeping them out of the hospital and keeping them healthy. You do it the other way around, there's no incentive for that. So the goal for being cutting edge and innovative is being killed by our current healthcare system and would be stimulated if we switch to a globally budgeted system.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
What about the administrative inefficiencies? You would think that today you could share data better. What are your thoughts along that line?
So when you look at international healthcare systems, it is very clear that single-payer healthcare systems are much more cost-effective and efficient than private multi-payer healthcare systems. This is true across all of our peer nations. Those that use single-payer tend to be much more cost-effective. Now, the flip side is that you lose some autonomy and choice. And whether a people or country want to focus on, streamlined efficiency and are willing to sacrifice some autonomy or choice or not, that's a cultural question. There's not a right or wrong answer to that question. That's a question of the culture of that country. So what I would say is, this gets back to the initial thing we said in this discussion. What is it we want? And are we interested in the efficiency that is intrinsic to a single payer system where you don't have to go through layers of this, that there's one payer, there's one authorization system, you don't have 15 different payers, you got to go through 15 different, sets of bureaucracy? Or do you want to have the choice? Or is that a false dichotomy? And you can actually coexist single payer and multi-payer in the same healthcare system, which other countries have successfully done.
Well, that's good to know. There's a benchmark out there. When we talk about innovation and improvements, there's a lot of things in play. You see people like Walmart starting to open up treatment centers, CVS with their health hubs. They're starting to open those up everywhere. You see other technology partners like Google and Apple, Amazon, with their pharmacy business, et cetera. Mm-hmm. A lot of things are kind of forcing change. And one of the things that I think has happened here recently, I'd like to get your opinion on it, is the virtual healthcare, AKA telemedicine, how this whole COVID-19 has possibly accelerated the acceptance of using this technology and bringing with it some maybe administrative and clinical efficiencies.
I'm told that the Chinese character for crisis and opportunity are the same. COVID-19 has greatly stressed us, and it has stripped away the veneer of the surface of U.S. healthcare and exposed the rot within. I will say that when you have 40 million people filing for unemployment benefits in a system in which healthcare is linked to employment, you have a problem. It exposes the unwiseness of having an accidentally evolved healthcare system. We're the only country in the world that links healthcare to employment, and there's no reason we should do that. That was the accident of history, the original sin that we referred to a moment ago.
Yes.
The flip side is that COVID-19 has forced us to confront some of the intrinsic inefficiencies in how we deliver care. It's kind of ridiculous to expect people to drive to a healthcare facility, fight to find parking, get lost to go into where they're going to go, sit for hours, get checked in, wait longer, when all they need to do is have a 20-minute phone call from their home or office and lose all of that lost time. And you want to be patient-centered. Let's focus on the patient's convenience, not the healthcare system's convenience. Telehealth has saved us in a lot of ways from COVID-19, but I think COVID-19 has pointed out that we really should have been doing telehealth a long time ago. And it's going to stay with us for a long time after COVID-19 goes away.
Yes, you mentioned Mrs. I in your book who lived in the desert and would come in for treatment. The social determinants of health can be remedied, I think, as well with some of this technology. I know we're starting to do virtual classes now at the university because we have to. And there's a lot of resistance to that, but we're trying to be adaptable and find better ways to get through some of these different times. But I think once we get through it, we'll find that there are better ways of doing things that we just didn't take the time to really focus on and to look at. What I'd like to do, Brad, in the few minutes that we have left, the reason I like your book so well, I mean, it points out, it dramatically points out a lot of these problems that a lot of people have written about before. The whole idea of pricing transparency and fee for service and these other terrible things, bankruptcy, people going bankrupt unexpectedly because of the things that are managed inappropriately with the health insurance. But what I really like about your book is at the tail end, you really go down the list of several things, doing an inventory of what we really want from a healthcare. And it's not polarized. It's really looking at things from a number of perspectives. So I thought I'd just kind of mention a few of these and you could comment on them as we kind of go down the list. Is that okay with you?
Sure, absolutely.
So the first thing we had on the list there was universal coverage. So what does that mean to you?
Universal coverage simply means that everyone living in that country has health care. It does not necessarily mean that it's delivered via single payer. People in this country have chosen in their own minds to link single payer to universal. They're not the same thing. All single payer systems are universal, but not all universal systems are single payer. There are private multi-payer systems in the world that are universal. We don't happen to be one of them. And if you want to solve our healthcare problems, the number one thing you need to do is get everybody healthcare.
I think Taiwan looked at that and made a switch, and it worked successfully for them. I think you covered that in great research in the past.
Taiwan switched from a private multi-payer non-universal system and intentionally sat down and spent 5 years designing and implementing and converted in 5 years to a universal single-payer healthcare system, and it worked very well. But I will also point out the Netherlands, Switzerland, Germany, France, they all have universal healthcare delivered by private multi-payer, not by single-payer. So universal can be delivered in different ways. The first thing we need to do is start with a universal healthcare system.
Great point. Number two, things we want. We want to eliminate gaps of coverage. Kind of unpack that a little bit.
In the book, I tell the story of a good friend of mine who I just texted with the other day, who had very good private insurance. He was a sales executive at a company and was, solid, upstanding member of society, living the American dream, had a great job, had a great family. He got a out of the blue illness that hit him hard. Nothing he could have done to stop it, just hit him. And within a year, he had declared personal bankruptcy and lost his house.
Oh, no.
Because as you alluded to earlier, there are gaps in coverage, even for people who are paying their healthcare premiums. There's deductibles and co-pays and per diems and co-insurance, and the list goes on. And even when you think you're covered, you can get hit with massive medical bills, even when you have insurance. This is not a problem in other countries. In the United States, more than 500,000 Americans per year declare personal bankruptcy, at least in part due to medical bills. That number in Western Europe is 0. So yes, the number one thing we need is universal coverage. The number two thing we need is to eliminate or greatly reduce those gaps so that when you're covered, there are very small, if any, payments that you need to make out of pocket.
Okay, I like that. Number 3, pay into the insurance pool. What is this insurance pool you're referring to?
So here's the thing about insurance. The way insurance works, because healthcare is so expensive, is that many healthy people have to be paying their premiums for every one person who gets sick. When you design a healthcare system that allows healthy people to not participate, the system cannot succeed. The costs of the sick people are so astronomical. If you allow healthy people to say, I simply don't want to participate, I'm not going to buy in, I'm not going to pay into the system, the pool will collapse. It'll undergo what's called a death spiral, where the costs continue to rise, such that premiums rise, such that healthy people say, I'm not going to pay those premiums, I'm fine. They drop out, and that just makes the whole thing worse.
Yeah.
We need to have a system in which everyone is paying into the pool, because we need many healthy people for every one person who, like my friend, was unfortunate enough out of the blue to get sick.
Wow. So unlike the U.S. Postal Service, I think the consensus was we don't want to rely on the government for our health care.
I'm going to go back to this. This is a really important point.
Yes.
Switzerland, the Netherlands, Germany, and France have private multi-payer universal health care. The difference is they have an individual mandate. And the Netherlands, which is by far the most cost-effective of those systems, has a truly draconian individual mandate. If you don't voluntarily participate, you get taxed the cost that you would have paid voluntarily plus 20%.
Wow.
In the United States, the individual mandate was so controversial in the Affordable Care Act that it resulted in the death of the bill, essentially. Right? Mm-hmm. It's still undergoing court challenges. Americans don't like mandates. And so this is the problem. Americans need to make a choice. If you really favor private multi-payer, the only way you can do it is with an individual mandate. If you don't like the individual mandate, the private multi-payer is not going to achieve universal health care, and you're going to set up that death spiral where premium costs rise, healthy people simply bow out, take their chances, and the cost of the sick can't be covered. And this gets to this blended model concept, which we'll come back to at the end. Does it truly need to be either or can we have both single payer and private multi-payer in the same system?
Yes. So the history of accidents, one of those histories of accidents might have been the employee tax benefit. That's another topic that fits into how we cover health care here for employers.
The reason why we are the only country in the world that healthcare access is linked to employment is because of two bills passed by Congress in 1942 to combat post-World War II inflation and raise the revenues the government needed to fight World War II. And those bills fixed salaries and wages to prevent inflation, but left employee benefits untouched, and then created tax write-offs to both the employer and the employee to pay for those employee benefits. The result of those two bills was that around 1 million Americans at the time were receiving health benefits from their employer. Within 10 years, that number was 80 million. 80-fold increase in 10 years. And that became so ingrained in American culture that if you were going to get hired, it was expected you were going to get your health benefits from the company. Yeah. There's absolutely no reason it needs to be designed that way.
A couple more points here, and that'll wrap up our list of 7. And one of them leads to what you talked of earlier, the American culture, choice. We like to have choice.
There are many people who feel very strongly that single payer is a better system. And to be perfectly honest, my own personal feeling is that single payer is superior in many ways. But here's the reality. Not all Americans agree with that. Yeah. Many Americans do not like the idea of the government being the single payer. They want a private multi-payer marketplace. And the reality is this: two different people or two different groups of people can look at the same facts and have different opinions about what to do. Neither is intrinsically right versus wrong. If we don't reach across the aisle, if we don't look for win-win solutions, if we say, I'm going to win when you lose, nothing will change. And we will continue to get ripped off to the tune of trillions of dollars per year in excess taxes and lost wages. We can make those two coexist if we reach across the aisle and recognize that it's okay for different people to have different perceptions. If we can create a system that is culturally aligned with the intense desire many Americans have for choice, but still allows everyone to participate, we can make a system like that work.
And that allows us to keep private insurance if it's part of our choice process there. So
exactly right.
I'm excited about your book. I'm excited about your research. I'm excited about your sharing the views. And we want to continue to follow what you're doing and help promote some of the ideas that you're expressing here, because it all affects everybody. This is not something that aligns one way or the other. Health is the most important part of our existence. And everything we do to sit down and stop and ask the questions, what do we really want? Try not to continue on with our New Year's resolution of continuing on with this idea that we'll just try it again and see what happens. Things do have to change. And I think collectively, I think we can be unified. And maybe this COVID-19 is one of these unifying factors for us. So I want to thank you. Your book's available out there on Amazon, I assume.
Yep.
And so I wish you good success with that. Broken, Bankrupt, and Dying, How to Solve the Great American Healthcare Ripoff. It's been a pleasure interviewing you for the Business of Healthcare podcast, and we'd like to catch back up with you again. Thank you, Dr. Spellberg.
Thank you very much. I look forward to it.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.